but I just want to have like just a short background about my research. I started doing AI back in 2009 and until today, and I moved from different countries, Iraq to Malaysia, then Taiwan, and here Australia. So today I'm going to talk about the AI in medicine and healthcare, for the past, present, and future, right? And the content of my presentation is going to be like four main elements. I'm going to talk about the AI, the history of AI, application of AI, challenges of AI, and then the AI development. Then where is the breakthrough of AI? Like, at what point we get more engaged with AI? And then finally, we're going to AI in medicine, where I'm going to brief you about AI in medicine and some of the work that has been done in my lab, right? So let's just start with the first thing. Like, what is AI? AI is nothing but a bunch of algorithms developed based on mathematical models. Previously, it was difficult because it's required mathematicians, people who work in machine learning, computer science, people with high level of technical skills. But nowadays is no more, since like the visualization is easy, the libraries, coding, everything is going to be easy, and even some courses are implemented for AI, like master of AI with no coding. So there are some courses even implemented based on no coding AI. Uh, but behind that, there is like algorithms. So this is the first element. Second element is the computing devices, the processors and the GPU, the graphic cards that do all the processing that required by the algorithms. And the last one, which is the data, right? And these three elements make the AI, right? Uh, so some people, they think like, okay, AI is a new topic, and 2022 people, they start having some, you know, they believe that AI is exists. Before that, when I teach AI, people, they think like it's all science fictions and things that only appeared in in the movies, or maybe like the big companies. But that concept is like not correct, because AI has been exists since 1950s, but these three elements, the algorithms, the computing devices, and the data, was like, the racing horses. Every 10 years there is like a development in, for example, the algorithms, but these algorithms, for example, cannot be handled by the computing devices. And when we create like a new computing devices, like strong computing devices that can handle the algorithm, then we are lack of data. When we provide data, then again we will have like overflowing data. So we need bigger computing devices. And then when we have bigger computing devices, then we found there is a problem with the algorithms. So we keep developing the three until at one point in 2000, I think 16 or 17, Google, they started talking about their chatbots, the generative AI, and they created the first chatbot. And since then, AI start touching all these big enterprises, and also in 2022, it's become like more human interactive. So people, they know that AI is exist, but AI has been there for years, maybe like since like 2000, maybe not 2000, even like 1950s, right? Okay, so this is the timeline of AI. So I'm not going to go through the whole process, but I mean the whole timeline. I will just jump through a few points in the middle of, for example, 2000, like between 2010 and 2012 was the one of the biggest breakthrough in AI, where they created the deep learning algorithms, and after that the transformers. And 2022, AI become more interactive. I mean, people, they with no IT or AI skills, they can interact with machine learning, with AI, right? Yeah. So I think like this is all timeline, so I'm not going to discuss it one by one. maybe later on when we want to go for more uh, detailed course, right? Uh, Now, the application of AI, AI has a variety of application. For instance, automation, car automation, the vacuum that we use in our houses, the robots, the automated cars, the data analysis, transportation, agriculture, healthcare, astronomy, gaming, everything in our life nowadays is interacting with AI engine, and this AI engine is creating more smart applications, right? Um, in healthcare, we have dozens of applications such as disease diagnosis, early diagnosis, production. For example, healthcare monitoring systems, some health informatics applications, the customized drug in the future, studying viruses, mutations, developing new vaccines. All of these are some of the AI applications in medicine, right? And it has application as well in finance, in retail, and transportation, as I said, education, entertainment, and manufacturing, right? Even agriculture. Uh, what are the challenges of AI? Basically, there are a few challenges in AI, not much, but some of them they are really big challenges. For example, when we talk about data bias, because basically machine learning working on the data that land on this data. Like for example, when let's say you ask ChatGPT about particular political question, then you will see that there is a bias in the answer, and this bias coming not because AI is biased, but because the data is already biased, right? So yeah, this is one of the things that we have to consider, the data bias when we deal with AI algorithms. Explainability and interpretability. This is like one of the main concerns, especially for those who work in medical field, because they want to understand like how AI is making this conclusion, or how AI arrived to this um, decision. Uh, we want to know the process, okay? And transparency is one of the things that was concerned previously in AI, but nowadays is no more exist, because we have some packages called XAI or explainable AI that can help you to analyze like how AI make the decision, not only giving you a system with high accuracy, but also telling you like how did the AI make this decisions, right? The other thing is the privacy and security. Of course, like this is like one of the main concerns. For your information, like we heard about chatbots, the ChatGPT, for example, in 2022, but this was exist like in 2000, I think 17. It was exist with Google, but they don't launch it because of this privacy and security issues. People will ask like, from where Google trained their model. So Google, they were waiting for someone to, to launch their product, AI product first, and they will see like what are the things that they are going to use. And right now, many of the big enterprises and companies, they are facing problem with the privacy and security, because the data they use for their model was private data. And 2 days ago, I was reading one article. They were talking about one of the AI models that read private emails from Microsoft, or they give suggestions from private information of the emails of Microsoft, right? So this is like one of the privacy and security challenges of AI. The regulations, like for example, whether this is safe, not safe, what policy can we use this or not. And also the final thing is the environmental impact. The environmental impact is one of the concern also for those who work in AI, because running the GPUs with which heavily use the power supply, it causes also some environmental issue. But maybe this one is the uh, is the lowest impact or lowest challenge comparing with other challenges, right? So in order to get like good AI system, we need to overcome these challenges, and then we'll think about the development of the AI. Now, the development of AI, the first thing that we are going to talk about today is the computing capacity, or the computing capabilities of the devices that we have to process the data. I don't want you to feel boring. I'm gonna pass these things fast, but just like introduction, I want you to have a look on it. The interesting part is the last part of my presentation. Right, so the computing capacity, this is like a small comparison that can tell you like the where we in 1970s and where are we now. The girl on your left hand side, she's Margaret Hamilton. She's the one who wrote the code for the Apollo project, the satellite that they sent to the moon. And this is the computer that NASA used to perform the control system. Now, I want you to have a look on this number, which is 12,200 something. This one is the number of operation, or they call it the floating point operation per second. Now, this number is the number of processes that our processor can do every second. Okay, so this was the number in 1960, 65 to 1970, and that was one of the best computer in the world. Okay, now this is a smartphone. Okay, and just have a look on the numbers that we have here. Okay, so we have 2.15 trillion operation per second, which is like 2.15 teraflops. Here we are talking about 12,000. Here we are talking about 2.15 trillion. And when we are talking about Samsung, for example, we are talking about 4.4 trillion operation or floating point processing per second. So this is our phone today. And this was the computer that sent Apollo, I think Apollo 15 to the moon. Okay, and this was the code written for that operation, or for that project. Okay. Now, comparing with today, today we are talking about if we want to interpret the same code, which was 145,000 lines of code in MATLAB, we can write it in or in these languages. We can write it between 3,000 to 10,000 lines of code. So algorithms become easier. Computing devices is higher, and we have a tremendous or massive data, so we can run AI for it. Okay, and this is the timeline of the development of the smallest unit of the processor. This is the transistor. Now, for your information, this transistor was one of the things that they consider the fire of, they said that this is equivalent to the discovery of the fire for the caveman. Okay, so this transistor is the smallest, or the brick of the processing unit that run the AI algorithms. Okay, and we put a list of them in this integrated circuit. Okay, and you can see here in 1970s we put 1,000 in one processor, and now we are talking about 100 billion transistor per processor. Okay, so we start from 1,000, and now we are at 100 billion transistor in a single processor. And they put the transistor, or the smallest transistor exists nowadays. The one in the market is 3 nanometer, and the one that is in the research testing or labs is 1 nanometer. and 1 nanometer meaning that is smaller than the DNA of a human cell, right? I will jump all of this and move to the data. Yes. That time is running fast. Yeah. Okay. All right. I'll jump fast. We have also some challenges related to the data complexity. Now let me just go direct to AI in medicine. Okay, so AI in medicine. This is the latest published article talking about if AI is ready for to be used in the market. Here is like one mother. She uploaded the X-ray of her son into Elon Musk AI, and she got the result of a fraction, while the GP said that there is no fraction, and she reported the case, and yeah, it was a fraction. So that's why England is giving the go ahead for AI to scan and help to detect bone fractions in United Kingdom. Okay, and this is one of the latest articles published in 2025, talking about suggesting the best hypothesis for studying some type of bacteria imputation. And the study was conducted since 10 years. And when they give the same scenario to AI in 2 days, they give them the top hypothesis that they have to start with. And eventually, it was the same hypothesis that researchers end with after 10 years. So yeah, nowadays Google has one AI tool called AI co-scientist. That one is helping people, or especially medical doctors, to form their hypothesis and then start with testing it, also to develop their methodology. All right. AI in medicine, it has like a different application in text, in image, in signal. Okay. We will just jump all of this and go to direct to research that I have done in my lab. All right. Okay, so part of the research that I had in my lab is EEG related research, and I did two projects, one with one of my master student and one with one of my PhD student. One is EEG for people who get depression level, and we analyze it, and we have seen like how to use binaural beat to reduce the anxiety and depression. Okay, and we did a protocol of 3 minutes, and we use it, and we come up with results in a pilot study of 30 PhD students. I did also a wheelchair control system for disabled people using EEG signal. So we use the EEG signal with motor imaginary to imagine like you are going left or right, and then we use this signal to control the wheelchair. Okay, and both studies was published in 2000, I think, 17 or 18. Right? And the other research that I have done related to CTG analysis, and CTG is for to monitor the pregnant woman, and it can help also to decide whether the delivery can be done in normal delivery or cesarean delivery. And based on the analysis of the CTG, and also that work, I have done this work with one of my friends in 2000, I think 11, right? Other research which I'm working right now on it is posturography research. Is about the losing or the fall, accidental fall for those who got stroke, and we do analysis for them to measure the risk of falling. Okay, and we published one study, and now we are working on another two studies. These two research is funded by Taiwan National University and Taiwan National University Hospital. So it's like both, and also from Taiwan National Science and Technology Agency. The other research that I did is some related to healthcare and some related to human well-being. The healthcare, we did ECG triage, patient prioritization, and chronic disease for chronic disease, heart chronic disease, and also for patient prioritization with multi-chronic disease for the emergencies. Also, we did some ECG-based hyperkalemia analysis and potassium level prediction. That project also I did in Taiwan. And I did some projects related to national childhood data center in Malaysia to analyze some longitudinal data for Malaysian obesity data, right? And I did also some early detection of dyslexia using machine learning, sensor-based sign language recognition for deaf individuals. And I did also gait analysis and classification. These are 3 funded projects. Some of my research was published during COVID-19 related to public health. It was about analyzing the public opinion about vaccine hesitancy. The main topic they discussed in the social media related to the lockdown, depression, government. People feel bad from the government, money, economy. So we analyzed the sentiment analysis for these cases. Also, I did some research on medical informatics, including medical apps, electronic medical record, and also integration of hospitals, data exchange, and other related research. One of the lovely research that I had, and I left it to the last, is related to white blood cell nucleus localization and segmentation, on which we did also leukemia classification, but that was outdated technology, and nowadays machine can do all the work. I did this research back in 2000, I think. I think in 2010. Yeah. All right. So I try to skip many topics in my presentation, but I hope that I just gave like some overview on what we are doing in AI AI in medicine. Thank you very much.
شكرا جزيلا دكتور بلال، شكرا جزيلا.
Very much.
الآن الدكتور زيدون الفلاحي، أخصائي أمراض القلب، وأيضا هو PhD candidate studying AI in health. دكتور زيدون، المايك لك.
السلام عليكم، شكرا على التقديم. Great presentation دكتور بلال. I'll do my best إنه not to overlap a lot with it. I will talk about a few topics. Let's start my presentation in a second. Sorry, بس لحظة. Okay, present. Just give me a second. Just find the share button here. Okay, can you see my screen?
أي دكتور زيدون.
All right, thank you. I will try to give some background into the concepts of how we look at AI from a medical perspective. Dr. Bilal has, gone into lengths to talk about AI as AI, but I think it's looking at it from a different discipline is to give it some more context. And always, I think the easiest context to give it is to think of AI in medicine as intelligence-based medicine. If you really think about what we do in medicine, we aim to process a lot of data very quickly and then give what we think is the most likely problem, and as well as what we consider to be the most likely solution. And that's what we called evidence-based medicine. But I think with this new paradigm of very rapid ingestion and analysis and processing of huge amounts of data, I think the whole paradigm of what is called evidence is changing. And that's why I think we're moving to a new era that we call intelligence-based medicine. Uh, I like to always to start with the definitions. What is intelligence? Intelligence is the ability to acquire and apply knowledge to achieve goals. And I think everybody here will agree that that's one of the core things we do in medicine. But then intelligence is based on knowledge. So knowledge is a foundation of intelligence, and knowledge itself is essentially using information in a useful manner. The foundation of knowledge is information, thus, which is data structured in a context. And data is the foundational layer of pretty much everything of artificial intelligence, but arguably also of what we do in medicine. And so data is the foundational layer. It's a number of discrete signals and facts that alone or on their own are meaningless. But when you put them in context of big data, then they come to mean something. An example of a data point is like the X-ray that Dr. Bilal talked about. The X-ray, the pixels, every pixel is a data. The doctor may have missed it, but the AI did not miss the fracture because it's been trained on a lot more data than the doctor. So every pixel is a data point. Every waveform in an ECG is a data point. So with that context, understanding what intelligence is, the bigger thing is wisdom. What is wisdom? And wisdom essentially why we use intelligence. What do you aim to achieve by using intelligence? What are your goals? I'll give you an example of some of the research I'm sort of doing. Uh, if you look at this ECG, and if you think that this ECG is normal, then not going to blame you because a lot of people think that this ECG is normal. I presented this ECG in a meeting for department cardiology heads of all of Australia, and everybody thought it was normal. But AI did not think it was normal. AI thinks that there is a 99% chance that this person has coronary artery disease. So what is it based on? I can't go into all the details, but the patient had an angiogram and essentially had triple vessel disease. Another example, another ECG, looks normal. In here, if you can see, this person is 47, 48 years old, but the ECG thinks that this person is 58 years old, which puts him at 10 years older than the patient actually is. Also, there's a 96% chance that this person has a coronary artery disease. If the ECG thinks that you are older, 10 years older than your actual age, then you've got a problem. 96% coronary artery disease. Well, we did an angiogram. The angiogram, sorry, that was the angiogram. That was wrong. But the angiogram was reported as normal. The question to you all, would you believe the angiogram or would you believe AI? To cut it short, this person has extensive calcification in his coronaries. The calcium score is severely elevated for somebody who is 47. So even though there's no luminal stenosis, this person again actually has extensive disease, and if it's not treated, it will lead to an adverse outcome. According to that, if we look at ECG done on an asymptomatic person, and that person was asymptomatic, and it could predict coronary artery disease, I want to give you an example of this ECG. And this ECG is my own ECG done with my Apple Watch. So we are able to do an Apple Watch. We can get a 12-lead ECG from an Apple Watch and an Apple Watch only with no other uh, wires or anything else. And then we get a 12-lead ECG that we can do an AI analysis on. And this is the whole um, disclosure from the Apple Watch looks like. These are all the leads 1 through to lead 12. And this is where it becomes transformative. When every, even consumer grade devices you have can monitor your health, you can see where this can be very, very transformative. And so my research focuses on the HeartWatch study, we'll start recruiting people to try to see the feasibility of actually getting 12-lead ECGs in the community. So I had the honor of actually participating in writing a chapter in this book, and my main interest is actually prevention, cardiovascular prevention. And I just want to, I like this quote by Joseph Fourier, which says that mathematics compares the most diverse phenomena and discovers the secret analogies that unite them. So essentially, as Dr. Bilal was saying, AI is based on algorithms. Algorithms need data. Finding patterns in the data is what AI is very good at, and that is also at the heart of cardiology. And so I think if I'll go with the rest of the presentation, but the one thing I want to focus that AI can be very transformative is what we call digital biomarkers. So you don't discover things with a troponin. You don't discover things with a CK or LDH or whatever. You discover them with a digital biomarker that is curated from your watch, from your phone, from whatever information there is. Also, this is a paper we recently published about the application of heart age. So essentially, normal, healthy people can have a heart age, whether from an ECG or whether from their own Apple Watches, and then we can actually be in the community and prevent things before people even turn up to hospital. And I think from a preventive aspect, AI is going to be very transformative. I'm going to be very honest about this. In the last 5, 6 days, I unexpectedly got extremely busy. I had to present at very short notice. I got data for 10,000 people. It's a very unique type, and we were meant to have there was meant to be a deadline for a conference this Monday, and so we were not going to submit to it, but for some reason they decided to extend the deadline to next week, and so suddenly I was tasked with doing a lot of work. So for the last 3 or 4 days, I had to present to people in the US. I had to do a lot of work, a lot of data ingestion, data analysis. Didn't have much time to do that. Didn't have much time to give this lecture enough time or work that I needed. So I had the option of recycling something I spoke about, and I spoke at length. But I thought, no, there are many ways. So how did I manage to meet some of my deadlines with the research? I actually started, because I need to use programming and R for my analysis, and I'm by no way a good programmer. So ChatGPT to the rescue is giving me all the code I need for doing all the analysis I need, and it's working. And that's one use that AI really transforms things. Things that I needed in the past to do over weeks, I can do now just by chatting. Also, preparing this lecture, I got AI to curate for me what I needed to talk about. I did this as a proof of concept to show you what AI can do these days. And I ended up with almost 39 pages of AI with, all medical references and in every utility. But I'm not going to present 39 pages. So I asked AI to summarize. This is an example of the analysis I needed to do. Sorry, that was the analysis I needed to do with which ChatGPT helped me, and this is all drawn with coding. And again, this is accessible to anyone and everyone these days. So I asked AI to take that outlook and generate a presentation for me. And this is the presentation. So what you are going to see now, I barely touched it. It was all AI generated. But I am responsible for the contents in it, and that's where it is key. I don't want to go through the history and the background. All I want to say is exactly AI is very old. It's been there for many, many years. It's always been part of healthcare, but in a very limited manner. The main goals of why we incorporate AI now into healthcare is not because AI was discovered now, but because now the technology has some maturity. And so we can rely on it and still have some consistent and safe outcomes. And it ranges from, not necessarily in diagnostic, but along the whole workflow. It can improve the accuracy, the efficiency, consistency. It reduces variability, workflows. Like these days, I no longer do my letters, for example, by dictating, sending a file by email, goes somewhere, who knows, somewhere in the world, comes back to me a week later, and I do everything on the spot with AI transcription on the device. I don't even have to send it online. So again, I'm not going to talk about the techniques. That's because Zaidan spoke them at length. But essentially, AI changed everything in cardiology. My personal preference, what I want to say that it can be transformative is in prevention. But in AI, in echocardiography, all the echo machines right now are equipped with a lot of algorithms to auto-detect ejection fractions, to facilitate things with a lot of reproducibility and little variability, which if you have expert operators, echo operators everywhere, this may not be relevant. But if you have less expert operators or trainees, this becomes even more. And by the way, even these images that you can see here, this image, I did not put it. This is something that AI generated. In cardiac MRI, again, cardiac MRI, as a lot of you know, it's very costly. It takes a long time. The analysis takes a long, long time, but AI is set to really speed this whole process significantly. Same thing for cardiac CTs. A lot of the detections in cardiac CTs now, for example, the calcium scoring is no longer manually counted. Calcium scoring is now automated, making these technologies much cheaper and much more accessible. Electrophysiology is still one area where AI is somewhat lagging, and this is probably due to it's being a little bit niche and it's being a very, very domain um, expertise sort of. There's not like to be able to do AI in electrophysiology, you really, really need to be a domain expert. And unfortunately, for some reason, that is happening in some companies, but not something that we've felt significantly to transform healthcare. In heart failure, AI, essentially, we can diagnose heart failure with a single lead ECG these days. And think about the impact of this in rural areas, in poor areas. You know, there is one of the algorithms from the Mayo Clinic was actually validated in Uganda, and with a single lead ECG, arguably just a single, even an Apple Watch ECG, you can diagnose whether somebody has heart failure or not with a very high accuracy. And the same thing with the software we use. Left ventricular systolic dysfunction is essentially can be diagnosed. So again, you can think about how you don't need an echo. You need an ECG to diagnose it. You need an echo to confirm it. Interventional cardiology, a lot of the imaging, because interventional cardiology now is no longer like before. You look, you inject, and then you just put a stent. There is a lot more going on in terms of physiological assessment, image analysis, and AI plays a key role in all of that. And prevention cardiology, I spoke all about it before. Now, I won't speak at length about the problems. There are huge, huge problems when it comes to applying AI in medicine. The most important of them is data quality and bias. You need to understand that health data is very messy. It's not clean. It has a lot of issues. And a lot of the engineers that work on it, unless they have the domain expertise of knowing where the signal lies, because you can train a model on anything, it doesn't make it accurate. The other issue is that most of the healthcare information we have comes usually from rich, well, affluent hospitals. Poor hospitals don't provide a lot of data. And so the algorithms are usually by default biased towards a different socioeconomic demographic. How that impacts other socioeconomic demographics is not something that is studied, but when it is studied, in some examples, there's been disasters. One example, how the saturation probe detects oxygen saturations differently between dark-skinned people and light-skinned people. In the majority of cases, this doesn't matter, but in intensive care, it's a huge issue. And there are publications on that. Dr. Zaidan mentioned about the black box problem. Also mentioned about the use of explainable AI, and there are a lot of algorithms that try to unpack it. But unless clinicians are involved at every level of the data curation and assessment, it remains problematic. Machine learning tends to be a little bit more explainable than deep learning, but now we are even moving towards reinforcement learning and other modalities, which are even harder to explain. And then obviously validation gap, which is why at the moment I'm too busy for the last week. Essentially, we found that our model, and as an example of where validation is a problem, our model, the one I'm using for my PhD, we verified it on multiple Western populations. It performed well. Then we got the 10,000 ECGs I told you about from the Tsimane people. And the Tsimane people, they're essentially Amazonians that still live in the Amazons. They live in the jungle, they hunt, they plant their own food. They are essentially foragers. They live a very primitive life. But there's a project where their ECGs were done over the years, and these ECGs essentially show that our algorithms give them older ages than they are. So it's a very interesting problem, and we wonder what the validation problem there is. Again, workflow integration, how we make use of AI, and then there is a lot of legal and ethical issues, which I think I just want to summarize. I'll just move past all of this, but I just want to summarize is, do we want AI to be on autopilot, or do we want it to be a co-pilot? And I think it's the role of AI in medicine is really to be a co-pilot. Thank you.
شكرا جزيلا دكتور زيدون، رائع كالعادة. شكرا جزيلا على التقديم الرائع. دكتور أحمد الربيعي، تفضل. أنت غني عن التعريف، الجميع يعرفك. دكتور أحمد أنميوت لأن ما جاني سمعك.
Right now, let me go to sharing. Okay. So the slides are clear now?
أي واضح.
Can you hear me? Right. Thank you, Dr. Bilal, and thanks, Dr. Zaidon, for the excellent presentation. Now, from my end, I'll try to focus on the clinical use and implication of AI. I was involved in some research with the Charles.
دكتور أحمد، آسف للمقاطعة، بلكي خلي السلايد على السلايد مود. يب، هذا بالضبط. شكرا.
نعم. العفو، بس في لحظة دكتور، لحظة. Right. Is it okay now?
Yes, all good. All good.
Yes. Sorry for this delay. So I said from my end, I probably here a consumer of the development of the AI, and I have only a little exposure to the algorithms and the models of the AI. Although we were involved with some joint research with Charles State University related to virtual reality, but I was covering just the medical aspect. Now, I'll try to be precise and focusing on the clinical use and application of AI in endoscopy and in disease management in gastroenterology. Now, for the endoscopy, the use in endoscopy, we use two main mechanisms based on the deep learning. Doctor, there is some, let me close this. Yes. On deep learning algorithm. We rely mainly on computer-aided detection in the localization of subtle pathology that we can't see with the human endoscopist's eyes. That's one mechanism. The second mechanism is the computer-aided diagnosis, which help in differentiating the pathology based on the virtual histopathology. And there is a joint mechanism where we use both the detection and diagnosis at the same time. This is applied to virtually all endoscopic procedures, but the most common one is the colonoscopy. Now, in the colonoscopy, we use the criteria of computer-aided detection. The most important quality parameters in colonoscopy and endoscopy, which differentiate the good endoscopist versus the average endoscopist, is the detection rate of polyps. We call it adenoma detection rate. So the higher the adenoma detection rate in endoscopist is the lower incidence of colonic cancer in his patients. Now, that's what appear on the colonoscopy using the AI. It is a circle there that even if you miss a pathology like this one here, it's easy to miss, by the way, with that. Then you can focus on that. So that's the polyp detection. And it was found that using the AI increased the adenoma detection rate by at least 27. This is from a few years ago. And there are more development, and there are more companies now entering the AI club. Now, the second mechanism is the diagnosis. So the AI model can use plenty of examples of the histopathology to differentiate between the high-grade pathology versus the low-grade pathology. We use what we call the pit pattern in one of the classification of polyps. And this pit pattern is probably one of the elements of the model here to differentiate this polyp versus this polyp. So this is another use of it and very helpful. The other use of AI is helping in navigating the colon. The colon is not straightforward tube that you can navigate unless after a long period of exposure and experience. But with the help of the AI, the navigation become easier. This will help the junior endoscopist, but also help the more senior endoscopist in difficult cases with adhesions, cases with difficulty, previous surgery, or hernia. And this definitely will reduce the time of the procedure, have the patient without much complication and so more comfortable. Now, in gastroscopy, we use both the detection and diagnosis criteria. Barrett esophagus, for those who probably have little exposure to, is the abnormal changes in the mucosa of the esophagus in relation to long-term exposure to acid in the gastroesophageal reflux disease. It is precancerous pathology or mucosa and goes through phases of low-grade then high-grade dysplasia before turning into adenocarcinoma. Now, these changes that you can see here, they are very subtle and very easy to miss without the help of the AI, but these are dysplastic lesion. Likewise, in this one, it's highlighted that. Without that, with just the white light of the endoscopy, probably it's hard to differentiate from the surrounding region. Now, by the way, it's estimated that at least 6% of the adenocarcinoma and Barrett's esophagus missed usually by the endoscopist. In the stomach, it's about 25% of early gastric cancer are missed, particularly those complicated intestinal metaplasia. And you can see the subtle changes here in those pre-malignant lesions, all these with the help of the AI. Now, the capsule endoscopy, probably all of you know that it is a camera to investigate the small bowel in this design. And it's in use for the last 25 years, introduced initially by a company called Pilcam. And they made different changes and upgrades of their software, but we're still struggling with the time and with the detection rate. Now, with the AI and with one of the latest development here, there are now a few capsule company using the AI. The sensitivity of the AI-based capsule is higher than this is the expert capsule endoscopy reader. And look the difference in the time of reading. The time of reading is around 4 minutes with the AI versus 33 minutes without the AI. So after 25 years of developing the software of the capsule, we managed to drop the time from 1 hour. I was reading the capsule study about 20 years ago, 21 years ago, more than 1 hour. We managed to drop it to 33. Now it's dropped to around 4 minutes to read an 80,000 picture of the study over 8 hours recording. So that is a huge progress. And I was approached recently by another company talking about 100% sensitivity in their model, in their AI model. So the figures probably are higher than this one. Now, in the endoscopic ultrasound, which is an endoscopic study using an ultrasound probe to check the deep changes in the related to the liver, pancreas, gallbladder, and the upper GI. Now, it is very important in differentiating between different variety of entities. IPMN is very common, but sometimes it's hard to detect, hard to find. Autoimmune pancreatitis, there is a mix-up and overlap between pancreatitis and adenocarcinoma, and there are a few Whipple's procedure done on autoimmune pancreatitis, thinking that this is adenocarcinoma, but in fact, it is autoimmune pancreatitis. And the sensitivity of AI in differentiation is high. Likewise, in differentiating the stromal tumor in the rest of the gastrointestinal tract versus benign one. In the liver, differentiating benign and malignant is dilemma for us, but with the EOS, make it very easy. Now, in gastroenterology, that's in endoscopy. In gastroenterology, it is, in fact, in managing diseases, in help managing the most important one. So in relation to GI cancer, AI helping management by the early detection. So by putting together the endoscopic images and the radiology data related to the same patient, plus the histopathology data, all these are aided by AI. So this is AI endoscopic image. This is AI scanning for the disease. And this is the histopathology, AI histopathology. By putting these together, early diagnosis of cancer is almost skewed, and we know the implication of such early diagnosis. Now, there are models which can be used in predicting the flares of inflammatory bowel disease, also by putting together the clinical data, the biomarkers in the blood and the stool, in addition to imaging, and then tailor the management according to this prediction. Because in IBD management, the most important thing is the sustainability of the response to the biological agent or to the agent used in the treatment. And liver disease also, the progression of cirrhosis from compensated to decompensated to liver failure, all these can be predicted to some extent using also the combination of data from the clinical data plus the lab data plus the imaging data. This is important also in liver transplant. Now, decision making, the AI is very helpful in decision making by putting all these to tailor the management or treatment plan for that particular patient. I'll stop here, I think, because the time limit. Thank you.
شكرا دكتور أحمد، شكرا جزيلا على التقديم اللطيف والسريع. الآن نفتح باب الأسئلة للجميع. شكرا طبعا دكتور بلال، دكتور زيدون، دكتور أحمد، المحاضرات قيمة جدا، برزنتيشن رائع، معلومات رائعة. باب الأسئلة مفتوح الآن. تقدرون تسألون على الشات أو مباشرة ممكن تسألون. دكتور زيدون، أنا عندي سؤال لحضرتك. بالنسبة للاي سي جي، اكو في الشغلات نقدر كأطباء نقدر نعرفها بدون استخدام الاي اي to detect the heart age او detect the coronary artery disease، لو هذا very complex algorithm؟
لا، مستحيل بالنظر، لأنه على مود، يعني على مود نقدر أحكي عربي ولا إنجليزي ما تفرق.
both is fine.
So to be able to get these features, we have to do a lot of processing for the ECG. So if you imagine what an ECG is, it's actually the movement of the electrical signal around the heart in real time. What we capture on the 12 lead on the piece of paper is essentially a bunch of squiggles, which reduces the complex data into something we can see. But if you try to analyze it in its original complex format, you will get far more diagnostic information. So how do we get that information? We essentially take the 12-lead ECG, we do what we call a transformation. So we try to return it into a 3D space to generate a vector cardiograph. So essentially it shows the impulses going in the X plane, in the Y plane, and in the Z plane. And then we look at the relationships between the different loops. Because if you think about the QRS, for example, it starts from the isoelectric line, goes up and down, and then goes back into the zero line, which in 3D space looks like a loop. And then the relationships between these loops, the complexity of their loops by using math that is above my level, but essentially, eigenvectors and eigenvalues, there are patterns that start to emerge. So the point is, no, we can't see this with our eyes. You have to analyze it in a very complex way. And that's why, in a way, I would argue that probably we should be using, or at least studying, the use of AI in any and every diagnostic modality we have.
وهل سؤال آخر، هل هناك يوجد يعني ابلكيشن على هذا الاي سي جي اقدر استخدمه بالوقت الحاضر لو ماكو؟
هو اكو ابلكيشن اذا تريد تستعمل yeah. اكو عدة انواع من الاي اي، واللي دا يصير الان انه everybody can develop an algorithm, and if you pass the FDA approval or the European approval, they market it as an app. بالنسبة للاب اللي أنا دا استعمله it's a research app. It's still not available in the market. بس إذا الواحد يجي يجرب أو يستعمل AI ECG، أكو algorithm مشهور اسمه PM Cardio, which stands for Powerful Medical Cardio. It's a subscription. You have to pay something. I don't know how much. It's not expensive, بس essentially أي ECG عندك تاخذ له صورة بالكاميرا مالتك التليفون. It's an app. تاخذ له صورة and it analyzes it for you. People non-cardiac, they swear by it. They say it's excellent. So you guys can judge. I don't know. I used to try it when it was still in beta, so they were just testing it like many years ago. It was so-so. I think it's much better now. But that's an example of an app that anybody can sign up to and try.
تحتاج مرضى للبحث مالتك؟
نعم.
تحتاج مرضى للبحث مالتك؟
لا، هو البحث مالتي ما يحتاج مرضى، يحتاج ناس أصحاء. So when we're looking for healthy people, I will let you know when it's live.
اوكي.
راح اخلي اللينك بالهاي البورفل ميديكال اذا anyone interested.
هل اكو سؤال اخر اعتقد؟
إذا تسمح لي دكتور، سؤال موجه للدكتور بلال. دكتور بلال، معلومات يحكي لحد الآن أكو 700 algorithm for AI. What the rate of just development of these algorithms? Because I presume that this rate will explain the speed of development of in all other fields using the AI.
عفوا دكتور ما
يعني
سمعت.
أنا سؤالي, my question is that 10 years ago, how many algorithms you were having versus 700? I knew lately that there are 700 algorithms right now. That's the question.
Yeah. Well, there are generations of AI that has been like going through like for the past 20 years. Nowadays they have it in a category called for example the old category, they call them the traditional AI methods, those who started with linear regression until the neural network, and then there is a new generation after that called the deep learning. That deep learning does not require feature to be extracted manually by a human. While we give the data, like for example, the posturography data that I gave to the system, it was trajectory data. I haven't extract any feature from it, and it's used its own filters and techniques to extract feature from. And now we have the latest models that we have, which is the transformative AI, the one they use for generative AI, the one they use for the chatbots that we have. It is like more than it's a kind of deep learning, but an advanced deep learning algorithms. So now, if you ask me a question like which one you prefer to use for medical applications, I would say the traditional methods they use is more trustworthy for doctors, because they can have like some explainability inside. It will tell you like how did they make this decision. But if you ask about the accuracy wise, of course, transformative learning is even better than the deep learning.
شكرا دكتور بلال. اكو سؤال من الاخ حسام. Can AI help with early detection and prevention of prostate cancer? دكتور زيدون، عندك فكرة عن الموضوع؟ Early detection and prevention of prostate cancer?
Not specifically about prostate cancer. A short answer إنه there will be and there definitely are some predictors of prostate cancer, or for that matter any cancer, but I'm not aware of any TGA approved algorithms for that, because having a research algorithm to detect something and having a clinical grade algorithm that performs like a medical device or performs like as a service, I'm not aware of that, but certainly there's got to be some work on that. The other question is, the other problem is to diagnose prostate cancer with what? From x-rays, from blood tests, from general features, from genetics. So that's one of the other issues. What information do you want to be able to make a prediction on? And that's why, there will be a lot of research, I can tell you that, but whether there's an actual product out there, I think it's a little bit hard to say for certain.
Maybe I can have like some input here. I have one of my degree students. He want to apply for a master degree, and yesterday he was proposing to me something related to this pancreas cancer, and same like Dr. Zaidon. I told him like I'm not aware of any approach before, but if you tell me like what kind of data do you have, like is it image, is it like genetic data? And of course, like if doctor can do it and it can tell me like what features they use to classify, then of course I can do it. But still, like maybe for a few years it will be like clinical studies until they reach to some some acceptable range of accuracy with some explainability, and then it will be again is a decision support system, is not decision system.
I was more interested about like any predictive analysis to say with all the data they gather about a particular person. There's a predictive analysis to say, look, this is potential, going to have prostate or pancreas cancer, any kind of like that.
Based on what, Sam? You mean
based on histopathology? Yeah,
genetically. You talk about genetics. You talk about symptoms. You talk about blood result. Or how do you? What do you mean?
All of that. The genetics, the blood test results. The normal sort of routine diagnosis. They do the doctors, the 2-yearly diagnosis. PSA. I can't remember what's those those sort of blood tests. So it's just the accumulation of all this data.
Yeah. This probably talking about screening more relevant to the prediction here, because you can't predict screening, which is a process going on in medicine in relation to prostate and other problems there. Screening, checking screening. And so far, I think the screening based on the PR examination and the PSA, and right. they developing the PSA. But one more thing here is that I'm aware of AI in radiology, which is now changing the face of radiology in all disciplines in relation to all.
Right.
So that which means that MRI for the prostate, for example, can pick up more subtle lesions in the prostate, which can develop into cancer. So this is, I think, something I heard about it in radiology in general, and I presume in, Likewise, by the way, I didn't mention about robotic, the use of AI in robotic and telemanagement. So you can imagine the importance of AI in this one. So what's here?
So can you see my screen?
Yes, Dr. Zaidon.
So you can open evidence. It's a free website. It's better than UpToDate. Essentially, it uses something like ChatGPT on all the papers available. And if you ask it a question, like, for example, AI screening for prostate cancer, it generates the answer, but also gives you the references. So I think this is, open evidence is probably one of the best decision support websites you can check. It's free, unlike, UpToDate or anything. And it is fantastic. And that's also another example of how AI is really, really changing things. If you want, we can actually...
دكتور زيدون اكو سؤال ثاني تقدر تخلي به اذا اكو سؤال ثاني على ال AI analysis is acceptable medical legally. I think it's all about the ethics.
Of course it is.
Is AI analysis acceptable medical legal? That's the next question.
Okay, so while it answers, let me show you something else that we can do.
Yeah.
So this is another website that's free. storm.genie.stanford.edu. It's free for now, and you just need to have your Google account, and then I can ask it present to me the legal and ethical aspects of using AI in medicine. Okay, and so I want to show you what it's going to do. The purpose is to inform a medical audience about the topic. Again, this is free, so any one of you can try this, and I encourage you to try this. It's going to work for a few minutes, and while it works, I go back to open evidence to answer your question, and then again, it talks about the different regulatory bodies, the FDA, the whatever, and what they do. The answers in this one are meant to be concise and to the point, but more importantly, you can check the references. And here the references talk about it. If you want to read about it, it's a very fascinating read. There's a WHO ethics of AI in medicine. It's a book, and it's a book that is actually very informative. This is the book. Again, it's free to download. One of the best aspects that the book talks about is that, you might think, who is in charge of ethics? Is it the doctor? Is it the government? Or is it the companies? The companies want to derive benefit, for their products. So the companies may not be the best keepers of ethics. And really, the big corporations, they can do essentially whatever they want. You can't really hold them to it. The governments, on the other side, they want to regulate AI, but at the same time, governments want to have social control. And, do you really want sort of a non-democratic government, or whatever democracy means these days, to be in charge of regulating what you can have access to and what you can't? So this goes into all of those issues, and there is no answer really that's clear. But it's a lengthy read. It's a nice read. Going back to the question that we asked to Storm, again, you can have a PDF file, download it, and then open the PDF file and show you what it looks like. So this is the PDF. It's about how many pages? It's 7 pages. And this is the table of contents. It's all AI generated. It walks you through the different aspects, all again with references. And you can find the references at the end if you're interested more. So these are ways that really your research can be really, really, really helped and promoted. And that's why I don't like to call it artificial intelligence. I like to call it augmented intelligence.
And this is free, the last one, the Stanford
It's all
one.
free.
Thank you.
Yeah, it's all
Oh my
free.
goodness. That's amazing.
It's all free. And if you haven't used DeepSeek yet, please do. You have no excuse.
Sorry, that was Storm, Dr. Zaidon.
Storm, the genie. Yes, Storm.
Genie,
The link is in the chat.
in the chat, yeah. Dr. Abu Shal Ubaid تقول great and very informative seminar. Many thanks to all.
Thank you.
السؤال عندي سؤال
تفضلي دكتورة بشرى.
شلونكم؟ Thank
الله
you,
يحفظك.
thank you for the information. It was really great. هسه من حكى زيدون على السيك ديب سيك هذه، يعني شنو الفرق؟ يعني هل هي greater than that, faster than the other one, or it's the same؟
خلي دكتور بلال يجاوب.
لا انت فتحت الموضوع زيدون.
أنا فتحت الموضوع.
مم.
واحدة من أكبر المشاكل ديب سيك بالنسبة لي، وأعتقد يعني خلي الدكتور بلال يصححني إذا أي شيء، نقلة نوعية بعدة مستويات. هذه الالجوريثمز اللي هسه راويتك اياها كلها كانت مبنيه على شيء، على ترانسفورمرز وعلى تكنولوجي كان مسويها اوبن اي اي. الى حد ما التكنولوجي موجوده، بس اوبن اي اي كانت يعني من 2010 2011 تشتغل على الموضوع، وكان دعمتها بها مايكروسوفت. فيعني انفستمنت مليارات الانفستمنت، وماكو شيء اوبن بالاوبن اي اي. يعني كلمه اوبن يعني هي كذبه كبيره. فهاي التقنية كانت حصرا فقط على الأمريكان. وطبعا اكو جوجل واكو ميتا واكو كذا، وتلاحظين حتى جوجل ما قدرت تنافس اوبن اي اي بسبب الالجوريثم اللي مسويه. وفوقها اوبن اي اي بدات تنزل الجوريثمز، يعني بالاول شات جي بي تي كان رخيص الى حد ما، بس بدات تنزل المودلز الالجوريثمز اللي فعلا انت تحتاجها، يعني تؤدي بها العمل، مو مجرد انه تساله سؤال ويجاوبك. لما ديب سيك نزل الموديل مالتهم اكو عده امور. اولا هم اثبتوا انه هاي التقنيه مو حصرا على الامريكان، معناها انه اكو كومبيتيشن مفتوح للباقين. الشيء الاهم من هذا كله بالنسبه لنا انه الالجوريثم مالتهم خلوه مفتوح المصدر، يعني انت تقدر تنزل ديب سيك تنزله بكمبيوترك، ما تحتاج انترنت. اوبن اي اي على مود تستعمل الموديل مالتهم لازم انت متصل بالسيرفر مالتهم، لازم تدز لهم كل معلوماتك وهم يردوا لك اياها وتدفع لهم اشتراك. ديب سيك تقدر تنزل على كمبيوترك نفس ان فاكت في بعض الامور اقوى من الاوبن اي اي. بهوايه
عجيب.
امور الديب سيك اقوى من الاوبن اي اي، ونعطيك اياه ببلاش تقدر تنزله بكمبيوترك. مو بس تستعمله بكمبيوترك، بس تستعمله لاي شيء انت تحتاجه. يعني اذا انت تيجي تسوي مثلا your own AI program تحتاج باك اند فد شيء، تيجي تسوي ايجنت. انا اريد اسوي ايجنت بالكمبيوتر مالتي، ادز له الايميل ويفصل لي اياه، تاكس منه مو تاكس منه. اريد اي شيء من هاي الشغلات الاوتوميشن اللي هسه نحتاجها، الشغلات الميكنه. ديب سيك يعني اصبحت يعني تقدر تنزلها وببلاش. فاللي صار الاحتكار مال الامريكان انكسر تماما. الا اذا نزلوا، اللهم الا اذا نزلوا يعني فد تقنيه ثانيه ما حد ما يلحقهم، هذا امر اخر. بس حاليا بهذا الجنريشن مال الاي اي الموجود، ديب سيك از از جود از اني. والامر الاخير انه، وهذا الشيء ما يخصنا احنا، يخصهم هم، قدروا يطوروه اقل من عشر اذا مو فراكشن من الكوست مال الامريكان يحتاجوه. فقلت لك الامر يعني يقلب الموازين كلها تماما على
خوش
الامريكان ويكسر
معلومة،
احتكارهم.
خوش معلومة. لأن صارت هبة
وانطوها
عليه قبل
ببلاش، لا
3
وانطوها ببلاش
أسابيع
للكل.
وبعدين هدأت. يعني
اي اي اي.
كأنه عبالك صار عليه فت حرب، لأن
هو
قبل
طبعا
3
حرب. هو
4
هو انت كل ما
يعني.
انت تروح تستعمله يعني هو كلش بطيء، بعد ما يلحقون.
مم.
بس مع ذلك اللي تقول انه يعني هم كسروا الاحتكار وانطوه ببلاش، هاي شغله يعني قلبت الموازين فعلا.
أكيد.
هو مو بس السعر، هو عندهم مسألة ثانية. الترانسفورمر اللي يستخدموه يعني اركتكتشر مختلف، يعني فكرة كانت كلش حلوة، يعني يسمون ميكتشر اوف
انستليشن.
اكسبرت. اي ميكشر اوف اكسبرت، يعني هذا يعني فشي جميل. يعني اللي شفت الالجوريثم مالته كيف شغاله، يعني فشي جدا جدا حلو. وصراحة يعني تميزهم هم، ولو شوية الصينيين يعني بالغوا من قالوا ب 8 ملايين دولار فقط التريننج مالتهم كلف. يعني ما حسبوا لا داتا ولا كل شيء، يعني حسبوا فقط الكوست مال الجي بي يو اللي استخدموه. لكن بالنسبة للريزنينج وبال يعني جاستيفيكيشن ليش هو جاوب وليش كذا، يعني مور ترانسبيرنت عن يعني الاوبن اي اي موديلز مال اوبن اي اي. وصراحة يعني تجاوزهم.
يعني اني من اجرب فد الجوريثم اذا اشوف فعلا هو شلون التدريب مالته. انطيهم قصيده عربيه قديمه عمرو بن كلثوم ومن جماعته، اذا اشوف يعني ديب سيك قوي لدرجه انه اذا تنطي مثلا ان اولد يعني شعر بيت قديم، مو بس يترجم لك اياه بصحه، بس يقول لك حتى هذا البيت منين ومنو قاله. ف I'm surprised. I'm very surprised.
صح.
مساء الخير.
مثلا
مساء الخير.
الحقيقة كلش حلو كانت اليوم المحاضرة، وأنا أشكركم جميعا جدا جدا.
عفوا.
كلش لطيفة وكلش يعني informative حقيقة. والسلام عليكم كلكم، مشتاقين.
شكرا جزيلا. طبعا أعتقد راح ننهي الآن المحاضرة. شكرا جزيلا.
دكتور إذا تسمح لي قبل ما تنهون، طبعا أنا ما خبرتكم، دكتور بروفيسور أوس أيضا موجود بالميتينج، يعني ما صار وقت أنه أعرفكم عليه. هو تقريبا يعني البارتنر مالتي بكل الريسيرش اللي أنا اشتغلت قبل، وشغال وياي بنفس الجامعة، ويعني أيضا من الناس اللي عندهم ريكورد يعني كبير، يعني دخل لاستراليا بهذه الفيزا مال الديستنجوش تالنت. أيضا شغال اي اي، موجود أيضا بالجروب. إن شاء الله بالمستقبل القريب حنسوي ميتنج يعني مع دكتور أحمد.
أهلا وسهلا بروفيسور أوس الجبوري. أهلا وسهلا بك.
السلام عليكم. ما شاء الله عليكم، يعني كفيتوا ووفيتوا.
عليكم السلام.
الله يحفظكم. أنا جدا سعيد يعني بلقائكم وهذا المجموع الطيب، وفرحانين إن شاء الله يعني نشتغل سوا بالمستقبل بإذن الله.
مشكورين، وشكرا دكتور أحمد على هالترتيب اللي ترتبه. الله يعطيك الصحة والعافية دكتور أحمد.
شكرا جزيلا لجميع الحضور، والشكر موصول للأخ دكتور بلال الجبوري والدكتور زيدون والبروفيسور دكتور أحمد الرباي. شكرا جزيلا.
وين دكتور أحمد؟ أشو ماكو راح؟
أعتقد انهزم راح. يلا تصبحون على خير.
شكرا
يلا
جزيلا.
تصبحون على خير.
شكرا، تصبحون
شكرا.
على خير.
شكرا.
مع السلامة.
شكرا.